Welcome to the image evaluation of the clavicle. We will review the common projections, including the AP and the AP axial projection. We will review image analysis guidelines and common positioning errors and corrective actions. Image analysis guidelines for the AP projection of the clavicle state that the medial clavicular end should lie next to the lateral edge of the vertebral column. The clavicle and the superior scapular angle are visualized at the same transverse level. The mid-clavicle is demonstrated within the center of the exposure field. The clavicle and acromion process are included within the exposure field. Here are those image analysis guidelines for your review. When evaluating an AP clavicle projection, rotation of the torso can impact the appearance of the clavicle and its relationship with the vertebral column. If the torso is rotated away from the affected clavicle, the medial clavicular end shifts towards the vertebral column, resulting in superimposition over its structures. This rotation also causes longitudinal foreshortening of the clavicle. Conversely, if the torso is rotated towards the affected clavicle, the medial clavicular end will move away from the vertebral column. This positioning also causes longitudinal foreshortening, but with a different alignment of the anatomic structures. Recognizing these positioning errors is essential for accurate patient positioning and optimal imaging for diagnostic evaluation. We have discussed the importance of a mid-coronal plane being parallel with the IR when we are doing projections of the chest, T-spine, shoulder, any of these type of things. So this is applicable here as well. If you want a true AP projection, we need to ensure that the superior scapular angle is in line with the mid portion of the clavicle. When the superior scapular angle is above or superior to the clavicle, you have some anterior tilt. And so this results in some distortion of the anatomic structures. So it's very important to get that mid-coronal plane parallel with the IR. Conversely, when the superior scapular angle is demonstrated inferior to the clavicle, you have some posterior mid-coronal plane tilt. Again, please look for these things so that we ensure we are accurately representing the anatomy of interest. Go ahead and review this AP clavicle practice analysis and answer the following question. In this first practice analysis, you wanted to take a look and ensure that you got all your anatomic structures. We got from the clavicle to the acromion process. And we want to determine if there's any plane tilting or rotation. In this case, if you examine the medial clavicular end of this right clavicle, it is displaced from the lateral edge of the vertebral column. The patient is rotated towards that affected shoulder. In order to correct this imaging, we need to rotate the patient away from the affected shoulder to align both shoulders equidistant to the IR. Review this next practice analysis and answer the following question. So let's take a look at this practice analysis. First, we want to ensure that we have all our anatomic structures. We have the clavicle from its medial clavicular end, but we do not include the entirety of the acromion process. So we do need to account for that in our repeat image. Next, we want to look for positioning errors. Is there any rotation? So we're going to look at our medial clavicular end and determine if there's any rotation. In this case, there is no rotation. The medial clavicular end is aligned with the vertebral column. Next, we're going to look for any plane tilting. When you identify the superior scapular angle, you can see it is in a position way above the mid-clavicle. This is causing distortion of our anatomic structures. In order to correct this, we need to position the body or anatomy so that the mid-coronal plane is parallel with the IR. Take a look at this next practice analysis and answer the following question. So let's look at this practice analysis together. We want to ensure that we have all our anatomic structures. In evaluating this AP clavicle, we do not have a medial clavicular end, but we do include the acromion. So we have some two-part IR issues here that we need to take some corrective action on. We may, in this case, need to open the collimated field of view medially from side to side to include the structures. Next, you want to determine if we are positioned appropriately. At this point, I cannot really evaluate for rotation. However, I do see a AC joint and it doesn't look like it's rotated, but there is some positioning error. And in looking at the superior scapular angle, it is positioned inferior to the clavicle. This means that the patient's body was posteriorly tilted. In order to correct this positional error, we need to align that mid-coronal plane parallel with the IR to accurately image this clavicle. Let's move on to the AP axial projection of the clavicle. Image analysis guidelines for the AP axial projection of the clavicle states that the medial clavicular end lies next to the lateral edge of the vertebral column. The superior scapular angle will be visualized a ½ inch inferior to the clavicle. The medial end of the clavicle is superimposed over the first, second, and third rib. The middle and lateral thirds of the clavicle are seen superior to the acromion process, and the clavicle bows upwardly. The mid-clavicle should be at the center of the exposure field, and again, the clavicle to the acromion process are to be included within the exposure field. Here are those image analysis guidelines for your review. Go ahead and look at this practice analysis and answer the following question. Let's review that practice analysis together. First, we want to ensure that we have from the medial end of the clavicle to the acromion process, which they are both included within the exposure field. Next, we want to look for positioning errors. In this case, this is an AP axial projection, and analyzing this image, the mid portion of the clavicle is superimposing the third rib, which indicates to us that the clavicle is not in a true AP axial projection. We have some insufficient central ray angulation. Another reason that we should identify that the clavicle is not put in the true AP axial projection is because the clavicle is not positioned superior to the chromian process. In order to correct this imaging, we need to increase the degree of cephalic central ray angulation to get that true AP axial projection. We're going to quickly review AC joints. Commonly, they are done bilaterally at most institutions. However, I only have a few images that represent that, which we will get to after we review the image analysis guidelines. Image analysis guidelines for the AC joint AP projection state that the lateral clavicle is horizontal. The AC joint space is present between the lateral clavicle and AC apex. The lateral clavicle demonstrates minimal acromion process superimposition. The clavicle and the superior scapular angle are demonstrated at the same transverse level. The AC joint is at the center of the exposure field for both the non-weight-bearing and weight-bearing views. The lateral clavicle, acromion process, and superior scapular angle should all be included within the exposure field. This is an example of with weights. Should always put a identification marker labeling with weights and with which projections were with weights and without weights. Here are those image analysis guidelines for your review. Again, I just wanted to review what AC joint rotation looks like. A patient who is rotated may have more open joint space on one side than the other. Also, the joint spaces may be closed. You also want to utilize your medial clavicular ends in a bilateral projection. You want to determine whether or not they are lying along the lateral border of the vertebral column. If you examine this image here, you can see the which image demonstrates with distortion, which is the one with rotation, and how the visibility of detail on the image without rotation. This concludes our presentation. If you have any questions, please feel free to reach out. Thank you.